I'm Levi. I'm one of the current R1s, and I'll be talking about radiation safety today, mostly in the context of us, but mentioning a little bit about our patients as well. Before I start, though, I'd like to thank Dr. Forbes for helping me through my first Grand Rounds presentation. Thank you. To start off, these are the things I'll be talking about today with a brief overview of what radiation is, how it's measured, and how much is safe. Then I'll talk a little bit about radiation to our patients before talking about how much that we, the physicians, are irradiated. Then I'll go into why this is even important and the risks associated with radiation before finally talking about how we can reduce our radiation. And this will mostly be from an endourologic perspective for that part here. So just for fun to start, this is a photo of the first X-ray machine that was invented in 1895 by Wilhelm Conrad Röntgen. The X-ray to the right is the first X-ray ever taken, and it is of his wife's hand with her wedding ring kind of blowing up there with how much radiation she probably got. So obviously since then we've come a pretty long way with both our technology and with understanding radiation. So what is radiation? Well, it's not just one thing. There are several types and they each have pretty different properties. So alpha radiation is made up of mostly heavy particles, 2 protons and 2 neutrons. And it's often emitted naturally. So this is what radon gas is. It's pretty easy to block even with something like a sheet of paper, but it can actually still cause damage if it's inhaled. Then we also have beta radiation. It's made up of small negative particles like electrons. And this type of radiation is what is used in things like carbon dating. And it's also relatively easy to block. It can penetrate your body, but it won't go all the way through. It's also used in medicine for things like different types of injections or in PET scans. Then there's a type of radiation called neutron radiation, and like it says in the name, it's made up of neutrons. And since they have no charge, this is a type of radiation that can typically travel quite far and is usually only stopped by either large amounts of water or materials that are made up of small atoms, and it's the type of radiation that's used in nuclear fission. So these 3 types of radiation are considered to be corpuscular radiation, and they're not really what I'll be talking about today, but I just wanted to mention them for completeness. The radiation that we'll be more concerned with today is the electromagnetic type. So this includes X-rays and gamma rays, and it has a very big range of energies. And these types of radiation are able to penetrate the body, and they can be blocked by things like lead or concrete. So the WHO definition of radiation is energy that travels in the forms of waves or particles. And here is the little graph kind of showing the different types of frequencies that each type of radiation has. So it's a representation of electromagnetic radiation, and the differences in frequencies change the classification and the properties of the radiation. So the waves can be ionizing, meaning it is released by atoms and travels as electromagnetic waves like the X or gamma rays, or it can be non-ionizing. And so that means that the electromagnetic waves don't actually have enough energy to cause the ionization of atoms. Excuse me. So these are things like magnetic fields, microwaves, lasers, ultrasound, or visible light. And the effects of this type of radiation are typically mechanical through heat or chemical changes and would cause things like a sunburn. And then radiation can also be classified as natural or artificial. So the simplest example of natural radiation is radon gas that is released in the environment. Like mentioned before, it's an alpha type. And the artificial radiation, like the name suggests, is radiation that we've created. And this is things like nuclear power generation or many types that we use in medicine. And So radiation is measured in several different ways, and it gets kind of complicated and complex, so I'll try to go through them all. So to start off, we have radioactivity. This is the amount of radiation that is released by a material. And it is what was studied by Marie Curie, so it's units, that's why they're called Curies, or becquerels. So 1 becquerel is 1 radioactive decay per second, or 1 nuclei disintegration per second. Basically, this is the rate of radioactive emissions from the source of radiation. So for an example, water has typically 0.0037 to 0.0185 becquerels per liter, or 0.1 to 0.5 picocuries per liter. So the safe limit recommended by the US standard is 0.185 becquerels per liter, or 5 picocuries. So typically water is way, way under the limit of what is recommended. So then there's the absorbed dose. This is the amount of energy that is actually deposited into the material per unit mass of that material. It's measured in grays, which are joules per kilogram, or rads. It does not tell you anything about the effect the radiation will have on a tissue, and it depends on the type of radiation, like alpha, beta, gamma, or X-rays. And not all tissues in the body absorb the same dose. So tissues closer to the surface of the body will receive a larger dose than deeper structures. So for example, a chest CT delivers 10 milligrays, or 1 rad, to the thyroid specifically, based on its location. So then this brings us to the dose area product, or also called the Kerma area product. So this is the product of the entrance surface dose and the beam area irradiated. It is independent of the distance from the source, and it reflects the dose within the radiation field and the volume of the tissue that's being irradiated. So it's measured in grays per centimeter cubed, and it's calculated on our fluoroscopy machines using the ionization chamber on the X-ray tube collimator. So it's one way that stochastic risk can be measured, and I'll tell you a bit more about what that means later. So now I've talked about emitted radiation, an amount that hits the body, but in order to talk about how much is actually deposited into a material, depending on the specific type of radiation being used, we need the equivalent dose. So this is the amount of energy deposited into a material per unit mass that actually accounts for the type of radiation. So this matters because different types of radiation have different effects on tissues. So for example, alpha particles have the potential to cause 20 times more biological damage than gamma rays, X-rays, or beta particles. So it's pretty good. They're easily blocked by things like paper. And this is reflected in their weighting factor, where gamma rays, X-rays, beta particles have a weighting factor of 1, and alpha particles have a weighting factor of 20. So that's indicating that it can cause 20 times more damage. And the equation is there on the slide if you're interested of how the equivalent dose is calculated. And it's measured typically in sieverts. So then to understand what this means in terms of radiation to tissues in our body, we have to talk about the effective dose. So this is the absorbed dose that I just talked about a couple slides ago, after it has been adjusted for the radiation type and the sensitivity of a specific tissue to that specific type of radiation. So typically cells that are dividing faster are more susceptible to damage by radiation, and have an increased risk of being damaged compared to those cell types that divide slower. Because this is tissue specific, it is just a mathematical construct. It's not an actual physical quantity that is actually measured. So it's just purely from an equation. It converts the equivalent dose that we just talked about to a specific organ into a standard that can be used to assess risk for different patterns of exposure. It's intended only to be used as an indicator for long-term health effects in a population, not to be used to determine individual health effects, because it's only a calculated approximation and not an actual measurement. The values used to calculate it are based on population group averages that are used as reference models. So because it's based on populations, it's often used for radiation protection planning. And the effective dose only applies to stochastic effects. So those are things with endpoints of cancer or hereditary damage. And again, I'll go into that a bit later. It's not predictive of future cancer incidents, though. It does indicate the probability of a harmful effect of radiation exposure depending on the part of the body that was exposed. So hopefully to simplify that a little bit, I put this picture there on the left where you kind of just put in absorbed dose, factor in the weighting factors of the type of radiation and the tissue, and then out pops the effective dose. And for an example of this, each tissue has a specific weighting factor that's used to calculate this effective dose, and this is called the effective dose equivalent. So tissues that divide faster have a higher weighting factor to reflect their susceptibility to radiation damage is higher, and tissues that divide slower, like bones or skin, have lower tissue factors because they're less susceptible to the radiation damage. So in the calculation here, we have a radiation dose equivalent of 10 millisieverts. So to determine how much radiation is absorbed by the thyroid, we multiply the 10 millisieverts by the tissue weighting factor of the thyroid. So now that we've kind of gone through all the units and what they mean, we can talk about what some typical doses are. So sorry if this shows up pretty small with the words, but this is an image taken from the Government of Canada's Radiation Nuclear Safety website. So it shows how much Canadians are typically irradiated just by existing in Canada. So the average background dose of radiation in Canada is 1 to 4 millisieverts per year. And it's such a big range because it actually matters where you live. Different places have different radiation emissions. And so to put this into context, the graphic shows that it takes about 1,000 millisieverts to get radiation sickness. And if you're an astronaut working on the ISS for a year, you get about 150 millisieverts of radiation. So you'd have to be out there for quite a while to get radiation sickness. This compares to a chest CT that gives about 7 millisieverts, and a cross-Canada flight gives you 0.2 millisieverts, or a dental x-ray that gives you very, very low at 0.005 millisieverts. So these are just some couple more slides that show typical doses that patients would receive from specific studies. And then here are some typical doses of some things that are a bit more relevant to our patients, specifically for our urology scans. So the government actually puts out these reports every year that show how much radiation different groups are exposed to. So interestingly, they include chiropractors, dentists, veterinarians, physicians, and all of their assistants and technologists in the medical definition. So that's the one I pointed out there, but they go into pretty much every job you could have and separate it into these different categories and by province. So they also separate the values into the mean dose and the non-zero mean. So they took out all the data from those who had no radiation exposure in the zero or the non-zero mean. So if we go by that, the report from 2017, which is the one I showed here, shows that medical workers in Canada generally are exposed to 0.53 millisieverts per year on average, and BC actually has the lowest in the country. And this chart here is taken from the same report and breaks it down by specific medical professions and by the year. So this took out all of the chiropractors and vets and things like that and is just showing physicians. So it shows that we have actually been able to decrease mostly our radiation exposure per year as physicians.
Levi, can you go back a couple of slides? So I just want to see what the typical doses are for each of the, there we
This
go.
one?
Yeah, thank you. So IVP. So the CT urograms where you go through 3 times, right? Without, and then with 3 times, obviously, because then you go through with the early arterial phase, then a delayed phase to see what the ureter looks like. And then, okay, good. So low dose protocol multi-detector, which we do have. And it really just depends on your BMI. So you can get quite low at 0.98, 1.5. That actually can be, and we've played around with it where you can get it even lower if you're just looking for stones. Obviously, if you do that, you won't be looking for cancer. That's when you need the CT urogram or a abdo pelvis, which is going to be 7 to 8. So it does depend a little bit on your BMI, but I think these are good numbers to hang your hat on. And are you going to be talking about like stochastic effects and what age group we kind of sort of have a little bit of a cutoff where we're more likely to do things?
I go into stochastic and deterministic effects, not specifically ages though.
Okay, well, we'll talk about it afterwards. Keep going. Thank you.
And if we're talking about the different doses for CTs, one other comment, I don't think it's as relevant for here, but some places have tried to reduce the low dose CT even further by just doing, instead of a whole KUB pelvis protocol, just doing the abdomen and then further imaging if there's hydronephrosis. I don't know that approach makes a lot of sense in Canada because it's so hard to get people into the scanner. Whereas in some other places, you could do follow-up scans a bit more easy, but it's just one of the many ways you can reduce the dose further just by limiting the size of the field.
Yeah, so we do that in really young people here. We can try to do that, but it's often very difficult because the techs will just basically do the whole thing. Even if you're just looking for like a UVJ stone, you want just pelvis. Conversely, on the other side of that is that with the in the US, sometimes they don't do low dose at all. Everything's just like, even for a CT scan, everything's just maximal dose. So you're doing a CT scan for stones and they're getting 8 to 10 millisieverts all the time.
Okay, so I think we were here, yes. So kind of going into what you mentioned, Dr. Chu. So different types of radiation have different types of measurements, and they have different types of effects, and it can be kind of confusing. But there's 2 main effects of radiation, deterministic and stochastic. So deterministic effects are what happen after you exceed a specific dose at one time. They are not additive and are a reflection of direct cell death. So they're acute radiation effects that generally happen just days or weeks after the exposure. They include things like skin burns, hair loss, cataracts, acute radiation syndrome, radiation sickness, sterility, and tumor necrosis. And some of the thresholds for those are mentioned on the slide there. So these effects each have their specific thresholds. So they only occur if that threshold is exceeded. So for an example, a burn will occur on the skin if more than 2 grays is delivered to an area, but it will not occur if 1.9 grays is delivered for that same procedure. So this makes deterministic effects very predictable. This is basically the opposite of stochastic effects. So these have no specific threshold for effects, and they include things like malignancy and respiratory, cardiovascular, and GI diseases. The risk of developing these rises linearly with increased doses, but unlike deterministic effects, the severity of the disease is independent of the dose. So there is an increased probability of developing disease with higher cumulative doses, but not a threshold. So basically, the more millisieverts of radiation that you're exposed to over time increases your probability of developing disease. So unlike the deterministic effects, the stochastic effects will show up years later. Malignancies associated with radiation are talked about more specifically a little bit later, but I just wanted to go into kind of what these 2 different things meant. So this graphic here just helps delineate the 2 ways a bit more visually. So deterministic is a bit kind of like all or nothing, where after a one-time dose, your cells either die or they don't. And it happens relatively quickly and then will resolve. So you'll heal from your burn kind of thing. Your hair will grow back. Then there's the stochastic effects that are more a bit of a like roll of the dice, whether or not your DNA is permanently damaged or mutated in a way where the cells can go on and reproduce in basically a dangerous way, causing a malignancy over time. So now to talk about the guidelines, now that we've talked about kind of doses and exposures. So to make it a bit more relevant, we'll go into what our Canadian guidelines say about radiation exposure. So the limits are actually set by the Canadian Nuclear Safety Commission. They're separated into the public, who should have no more than 1 millisievert per year, and the nuclear energy workers and us, who I guess we're special, we get to have more radiation, up to 50 millisieverts per year or 100 millisieverts in 5 consecutive years. So if you're not planning on retiring in the next 5 years, it basically breaks it down into a limit of an average of 20 millisieverts per year. So the yearly limit of 50 millisieverts per year is equivalent to about 2 to 3 abdominal CTs per year, or the same as just living here for 7 to 9 years, getting that background radiation. And because the harms of radiation, there's actually Canadian laws that have to be followed in workplaces where radiation is a thing. So like us, the nuclear energy workers, that sort of stuff. We're legally required to wear dosimeters to measure how much radiation we're exposed to. I know all of the residents get these, and we're changing them every 3 months or so. Areas where radiation is made have to be labeled, so like outside of the CT or X-ray rooms. And we're also legally supposed to use the lowest dose whenever we can. So it's recommended people of the public only receive 1 millisievert of radiation per year. So how much are we giving our people of the public patients? So this often depends on why we're irradiating them. So as an example here, I'll go through a testicular cancer monitoring study that I found. So there's fairly high doses exposed to people undergoing malignancies. And again, I'm going to use testicular cancer for this example. So this is a study from 2009 where they looked at future cancer risk for people 18 and 40 who were undergoing the surveillance schedule that is laid out in the table there, for stage 1 non-seminomatous germ cell tumors. And they found that the 18-year-olds had a 1.9% or 2.6% risk of developing cancer secondary to their radiation exposure. The higher risk was for those receiving CT abdo-pelvis and CT chest instead of just an abdo-pelvis alone for surveillance or monitoring. The rates were slightly lower for those older. So the ones who were age 40 had a risk of 1.2% and 1.6% for either abdo-pelvis alone or abdo-pelvis and CT chest. And it had a relative risk of 15.2 compared to those who only had a single scan following an RPL&D. The cancers they were most likely to develop were colon and lung cancers. So the table here shows approximate doses received to each of specific organ when you get the CT abdo-pelvis, and the effective dose that we talked about earlier for each type of scan, and their respective lifetime attributable risk of developing a cancer in each of the measured organs. So this study didn't actually measure this through data of men developing cancers post-monitoring. They used methods from the report listed here to estimate the risk based on the exposures. So they didn't actually go back and see how many of their patients developed these cancers. It was more of a theoretical thing, but I thought it was still useful to mention, just as an example of what you can do to people's risk by just monitoring them. So then another group who we obviously irradiate quite a bit are the stone patients. So they get scanned during diagnosis, monitoring, and treatment of the stones. This is higher risk for recurrent stone formers, given that they, keep coming back and need more imaging. And so In one study from 2015, they showed that on average, a patient with a stone was exposed to 5.3 millisieverts for the diagnosis and treatment of that stone and had on average of 4 different studies done. So they're listed there with 1.2 KUBs, 1.7 non-con CTs, and 1 IVP on average. So this is 5 times the recommended limit for our regular people. And it's even higher if you have a higher BMI, like Dr. Chu mentioned, multiple tracts, or higher stone burden. So then doses for PCNL were similar to those of an abdominal CT, and ureteroscopy are similar to doses of X-ray. So the table here shows the effective doses for different types of radiography. X-ray is much less than a CT, non-surprisingly. CT trunk or abdomen can give quite high doses, here listed at 12.2 and 8.1 millisieverts per scan. And then this one actually also breaks it down by age for pediatric patients for how much they're being irradiated by each of these scans. So what can we do to give our patients less radiation? Later, I'll talk about procedure-specific methods, but generally for diagnosis, using a low-dose CT, as in its name, gives a much lower dose of radiation. It's also been found to have high sensitivities and specificities that are greater than 90%, according to a literature review that looked at 7 different articles. Ultrasound and MRI obviously would be the ultimate way to decrease radiation because they don't have any ionizing radiation at all. But they have a bit lower sensitivities and specificities in diagnosing stones. And ultrasound is typically only first line for kids or pregnant people, and MRI is used even less often. CT is currently the gold standard for diagnosis and is currently the recommendation for preoperative PCNL planning as well.
Just a comment there, Levi. I think you might use MRI pretty rarely in kids or pediatric patients, but often you can sometimes use ultrasound as sort of a first line when renal colic is suspected in the emergency department or for follow-up. And that's one of the ways we can think about using non-radiation imaging for patients.
Thank you.
That's definitely been the trend to do more ultrasound to get away from ionizing radiation. One of the things that's driving me a little bit mad is, as a reviewer for certain journals, for instance, I think Journal of Urology encourages that if you're going to do a study, that the follow-up has to be a CT scan to know that indeed this patient population really is stone-free, which is not very real world. And then if you're doing a study, then you end up exposing people to more radiation. So it's a bit of a double-edged sword. Keep going, Levi.
Sorry, just to add to Ben's comment. Yes, it is true that the trend in the academic literature is for post-stone intervention to do a CT-KUB because ultrasound misses stones, small stones in up to 30% of cases. And so as we're really trying to define stone-free, nothing beats a CT scan, and an ultrasound is not good enough. On the other hand, to echo the prior comment, there's really no loss to doing an ultrasound when you suspect someone has colic. And only if you don't get an answer, then you proceed to a CT scan.
Okay, thank you guys for your input. So we've talked about radiating our patients, but we obviously radiate ourselves as well. So the rest of the talk will be focused more on physician exposure and urology specific exposure in most cases. But most of this also would apply to our patients as well. So if you could keep that in mind while we go through the rest of it. So sources of different exposure, I'll start with X-rays. So this is used during endoscopic surgery, nephrostomy, ureteral stenting. And most of the exposure to providers is from the scattering of the radiation from the patient. And then because of this, when the X-ray tube is overhead, we have a much higher exposure than when it's below. So most of the time, the X-ray tube is actually under the patient for this reason. And in this little graphic here, the X-ray tube is above and it's showing all the little X-rays kind of scattering off onto you, onto your eyes, your hands, everywhere. So this slide shows the difference in effective dose to a urologist when doing ureteral stent exchanges over 2 3-month periods. So in the first 3 months, they used 15 pulses per second. And in the second 3 months, they used 7.5 pulses per second. And in the 7.5 time period, they also use collimation to increase the quality of the images, because by reducing the pulses per second, you reduce the quality of the image as well. But not surprisingly, you also reduce your radiation. So they found that we reduced our exposure to our eyes and our extremities. Exposure to extremities went from 33.9 millisieverts to 8.1 millisieverts per 3-month period. So that's significant given our yearly recommended exposure is only 50 millisieverts, and even less if you're going to be doing this for more than 5 years in a row. So this study didn't really specify how many procedures were done in each 3-month period or how long the procedure was, though. So this is the same study, and they reported the dose area product in each time period that the patients received. So it was also significantly decreased by using the 7.5 pulse per second setting during both stent exchanges and nephrostomy exchanges. So we reduced the radiation to ourselves, but also significantly for our patients too, just by changing that setting on the machine. So this one's looking at PCNL, and we also receive a lot of radiation with our legs taking most of it. So this study excuse me, did have the X-ray tube below the patient, and showed that the average absorbed doses to each body part per case in the table there. The average exposure time per case was 6.8 to 22.9 minutes. And our Canadian dose limits are in millisieverts, but here the UK dose limits I'll give you so that you can put it a little bit into context. So the UK limits recommend we don't exceed 500 milligrays to our legs, feet, and hands, and there's a limit of 150 milligrays to our eyes. So based on this data and assuming the average of 50 PCNLs per year that was done in this study, they concluded that urologists didn't even exceed 2% of the limit. But this only took into account radiation from PCNLs and no other exposures. And there was also only 6 cases that they looked at in the study.
Just a point, Levi, down in the stone center on that table, there are those little flaps that they have there on the lower part of the table. Those are actually lead shields. So you put that down below where the emitter is, and therefore it blocks everything from your feet, and also the shields in front of our face as well too, which you can use, which we tend not to use as much because it gets in the way of us actually operating. But the ones on the bottom really should not, we really shouldn't have an excuse to not use those, because those can be easily put into the way so we can reduce our radiation dose.
Oh, good. I haven't actually been in there too much, so I haven't noticed, but I'll keep an eye out. So another study here showed pretty similar results in exposures during PCNL. They had a mean effective dose of 12.7 microsieverts per procedure per urologist. So this means that you would need to do 3,900 PCNLs in 1 year to reach our maximum exposure limit of 500,000 microsieverts that's recommended. But again, this only accounts for PCNLs and not any other procedures that you'd be doing as well. So several other studies looked at exposure during URS and laser. So this study is from a Korean center, and they looked at 226 cases within 1 year where the X-ray tube was below the patient and the urologist was sitting for the lithotripsy. The doses here are reported as cumulative within the year, and they reported that the effective dose to the surgeon was 4.4 millisieverts. So they also broke it down by body part, which showed that the effective dose to the urologist's eyes and neck were well over the yearly recommended limit of 50 millisieverts per year, at 66 and 70 millisieverts. So this was true basically for all unprotected areas. They were all over the limit. And in this study, the average operative time was 83.2 minutes with average fluoroscopy time of 5.13 minutes, but they did not list doses per case. And then here, another study from 2015 studied exposure from both URS and PCNL together. They showed that the PCNL exposure was just over 4 times higher than for URS. They also reported that the annual dose to the surgeon's eyes was 29 millisieverts per year. So this is less than half reported by the previous group. They also included exposure to nursing, and not surprisingly, their doses were much lower, given that they're typically much further away than from the X-ray tube than we are. So this group also broke exposure down into rates with 0.9 millisieverts per hour for diagnosis and treatment, compared to 1.9 millisieverts per hour when using an acrylic lead shield. So very much decreases your exposure there. And the mean time for URS was 0.4 minutes and 3.7 minutes for PCNL. Then I found this interesting study. It showed that different lens exposures among different specialties. So sorry if the graphics are a bit small there, but basically they show that urology used about half the amount of radiation than cardiology, neuroradiology, interventional radiology, and vascular surgery. But they also showed that our exposures were much higher than theirs. And the difference here was that in the other specialties where the study was done, they all had acrylic shields attached to the ceiling that they would use. And the urology rooms didn't have this. So this was a study from Spain. So I guess their urology rooms don't have the shield, but everyone else gets it. And it really helps reduce their radiation exposure. And then just to touch briefly on exposure for our colleagues who may become or have been pregnant, I've included some data from a study that measured the effective doses to the abdomens of pregnant radiologists. It was quite a small study, but they showed that the exposure was extremely small when wearing lead, with being at home actually providing more radiation than when they were actually being irradiated. So this is important because radiation to the fetus has been shown to cause organ malformation, growth restriction, mental retardation, childhood cancer, and even some prenatal death. Most of the data, actually pretty much all of it, that we have for radiation in pregnancy is taken from Hiroshima victims, not actual studies irradiating pregnant women. But it is generally recommended that no amount of radiation is safe in pregnancy, and you should always wear properly fitted lead, especially around your abdomen, given that's where the fetus lives. So now we've talked about how much radiation we're all getting. So I'll start to go into why that actually matters and why radiation is not great to have too much of. So they can cause cataracts. So this study from 2017 showed that the most exposed urologists had an annual dose of 750 micrograys to their eyes. So this is about 5.64 micrograys per case. And only about 5% of the yearly limit was quoted here for the highest urologist, residents have over double the exposure to our eyes. And in this study, they were found to have an annual eye exposure of 1,710 micrograys, or 11% of the yearly limit. So luckily, this is still well below the limit, but this is much lower than the previously shown data from the other slides. So we know that the one group reported the average yearly dose to our lenses was 29 millisieverts with 468 cases of URS and PCNL per year, which is actually over the recommended limit. And this study was small, but it's comparable to another study report of 1.9 millisieverts per hour. So back to that one that gave us the rates during PCNL. So this means that you would need to do 10 hours of PCNL to reach the recommended dose limit of 20 millisieverts per year to the lenses. Then another typical dose reported was 0.9 per hour. So this means that you would need 22 hours of diagnostic and treatment radiation to reach the limit. Then there was another study from Germany that found that the average dose was 50 microsieverts per case, or 0.05 millisieverts, with the highest exposure reported at 290 microsieverts per case, or 0.29 millisieverts. So this means that 400 procedures per year would be over the limit. And if your typical patients had a higher BMI, this would be even less procedures per year to get you to that limit. They also reported that the experience level of the surgeon didn't matter, and it was across the board that they were getting these numbers. But given that cataract formation is supposedly a deterministic effect of radiation and is not additive, so theoretically you would need a one-time exposure of over 0.5 grays to form them, which I don't know how realistic that would actually be. So this is a bit more about the stochastic effects and how they cause damage. So I mentioned it a bit earlier, but basically the energy from the ionizing radiation is high enough that it can cause direct damage to DNA. It either breaks the strands or can cause mutations. It can also indirectly damage the DNA by causing formation of free radicals. So why does this matter? Well, as I'm sure you all know, DNA damage leads to malignancy. Malignancy is bad. So most data around the stochastic effects of radiation, again, come from studying Hiroshima victims. But it's been shown that for every microgray, you increase your risk of developing a malignancy by 0.00035 times. It sounds pretty low, but there have been studies showing that radiation technologists had an increased risk of developing melanoma, breast cancer, and brain cancer compared to their non-radiated colleagues. Interventional radiologists and cardiologists were found to have left-sided brain and neck tumors 85% of the time. And the sidedness is significant because the left side of your body actually has a much higher exposure to radiation. So this was suggesting that the radiation may be to blame for their left-sided specific tumors. It's also been shown that female orthopedic surgeons have a higher rate of breast cancer than the general population. This is important because most of our lead actually doesn't properly cover our axillary regions, and this is the area of the breast that's most commonly affected by breast cancer. So we might be kind of enhancing that risk by not fully covering ourselves in that area. There is also an increased rate of breast cancer and melanoma among female physicians in fields where they had higher radiation exposure compared to those with no radiation exposure. But interestingly, the men had an increased rate of leukemia where the women did not, and the men did not have the increased rate of melanoma that women did. So obviously, malignancy is bad. Radiation is linked to causing malignancy. So how do we make this better for ourselves, but also our patients, especially those ones that we're causing significant radiation exposure to? So we can start by actually knowing the risks. So an American study of 226 urologists, including academics, residents, and what they called experts, showed that over half the urologists actually didn't know exposure had anything to do with how far away they were from the source or how to determine or decrease the radiation doses that they were giving. So half had not read any literature about harms of radiation. 80% thought there was no literature about fluoroscopy doses. And this was a study from 2019. And throughout the previous slides where I quoted some fluoroscopy doses, the oldest one was actually from 2009. So there has, in fact, been literature about fluoroscopy doses. Another American study here of 165 urology trainees reported that only 53% of learners felt adequately trained in radiation safety, and only 13% had any training. Less than half of them knew radiation limits, and 56% had never been given a dosimeter. So that's pretty important given that it's actually law here in Canada. I don't know if it's law in America, but it is law here, so that's a bit low. And this is especially important because, as we've seen previously, residents have a higher exposure to radiation. So the most important thing we can do for ourselves is to wear PPE and track our exposures using dosimeters. So 4 studies showed that most urologists do actually protect themselves. Over 90% in all the studies wore an apron. It's a little bit concerning that fewer were wearing a thyroid shield, given that the thyroid is a rapidly dividing organ and so receives higher effective doses than most other parts of our body. And not so surprisingly, very few urologists wore lead glasses. And so here, it shows that sizing and fit of lead actually does really matter. But if it fits properly, they are very effective and typically block over 90% of scatter radiation. So for females, they need to cover the entire axillary region, as I mentioned before, is a high risk for breast cancer development. The skirts should cover the entirety of our long bones because marrow, similar to the thyroid, is a rapidly dividing organ. And we've also learned that the legs often receive the most scatter radiation. So you need to wear your lead, but you also need to take care of it. Any holes or wear and tear can make it less effective. So aprons are definitely important, but I also wanted to mention that decreasing the fluoro time was actually found to have a larger effect on decreasing radiation exposure to orthopedic spine surgeons than wearing lead was. So that is also very important. Lead glasses and visors are also options. Not surprisingly, a visor blocks more radiation than glasses, given they cover your whole face and not just your eyeballs. And here, this again just shows that the left side actually gets more radiation than your right side. Lead gloves are the least worn form of PPE, but they do reduce radiation to the hands by 15 to 30%. But they're generally not recommended because if they get in the field at all, it actually increases the energy required by the machine to produce a good image. So you actually end up increasing your radiation exposure to you and the patient. Then here, we mentioned briefly lead shields before, but they're very good protectors. And in this study, they were found to reduce radiation to the eyes by 13 times compared to not having one. They were also very effective in protecting nurses and technologists. So these next few slides I showed previously, but I just wanted to kind of reiterate the effectiveness of the shields, given that I'm new, so I haven't necessarily been everywhere, but I haven't seen people use them too much in practice, especially the ones that go kind of in front of your face. But here, urologists use much less radiation, but they were much more irradiated because they weren't using these shields, so they are effective. And then here again, it just shows that the shield reduced the equivalent dose to the urologist during URS and PCNL compared to having no shield by 15 to 95 times, depending on where the surgeon was standing. But the study didn't specify which positions were actually better than others. And then here is kind of just for fun, but lead is not the only protection. There's also these tungsten vests, Demron suits, and if you want to be really uncomfortable all day, you can wear bio-rubber underwear. So now we can move on to how we can actually reduce our radiation instead of just hiding behind lead. So this comes to the ALARA principle. So it's as low as reasonably achievable. And it's talked about in many studies, and there's a whole section in the AUA actually dedicated to it. So there are a set of principles that allow us to decrease radiation to ourselves and our patients if we follow these principles. So one of them is time. The best way to decrease the amount of radiation is to radiate less, use less frames per second, less pulses per second, monitor your fluoro time to see how long you're actually stepping on the pedal and irradiating everyone. And then you can combine this with using lower dose options to give you even less radiation. Then another main principle is distance. So the farther you are from the source, the less radiation you receive, and it's actually quite significant. So every doubling of your distance decreases your exposure by 75%, which is quite a lot. So it's lessened even more if you stand at the exit side of the tube instead of the tube side. And again, having the X-ray tube below the patient kind of helps with that, with our positioning. And then avoiding magnification also can help you decrease the dose. And then here, some of the things are actually settings on the machine that you can use. So if you use the lowest dose and put it on pulse mode with the lowest pulses per second, you really reduce your radiation. And the less pulses per second, the worse image you get though. So if you use collimation to restrict the image area, you can emit less radiation and increase your image quality. So the image on the right here is collimated and actually decreased the dose area product by 48% compared to the image on the left. Another thing you can do is to use the last image hold, so you don't have to fluoro repeatedly if it's not necessary. You can kind of just look at the shot you already have. And as mentioned before, when talking about the gloves, avoid having anything metal in the field or lead, because this actually increases the amount of energy needed to produce that same image. So specifically for PCNL, the AUA has
just one comment on that part, Levi. The collimation, I think, is important to distinguish from MAG, which is different. The collimation is where you're limiting the boundaries of the image, which gives you a smaller area that you're looking at. But then if you use MAG, it actually intensifies the image in a small place. And some people will have thought that decreases your dose. It actually increases your dose if you use MAG. So try to avoid MAG. So good collimation, good. MAG bad.
Yes. So for PCNL, the AUA actually has a document that suggests certain methods for decreasing radiation. So you can use ultrasound instead of fluoroscopy to gain access. Air can be used instead of contrast to confirm a suitable calyx for entry, because you can see the little air bubble where it's going. Ultrasound also allows for more real-time monitoring while gaining access than fluoro does, so that was a plus for that as well. Then using tactile feedback for guide wire placement can also reduce your fluoro. This, of course, takes some experience before it can be practical, so you have to actually be comfortable with knowing what you're feeling. And then they use a low-dose retrograde pyelogram and use less pulses per second and collimation, like I just talked about. And then when you're finished, you can use direct vision for stent placement. And then here, this picture, they're showing how they were actually using the scope itself to measure out how far in things should go. So here's some actual studies around this. So this one shows that fluoro-free PCNL, not only possible, but also safe and very effective. So this is a study from 2019 where they looked at fluoro-free prone ultrasound access, fluoro-free supine ultrasound access, and then standard access methods, standard fluoro use for the procedure. So in the non-fluoro groups, they use tactile feedback for the wire placement. And if people were known to have multiple tracks, they would actually wire both under direct vision and then tape one to the body so that they could keep track of which track they were in. And then they showed that there was actually no significant difference between groups for operative time, hospital stay, or stone free rate. The fluoro-free groups even had a lower hemoglobin drop than the fluoro group as well. But overall, the authors said that it was equally effective, safe, and feasible as conventional PCNL to do it this ultrasound-only way. And then another study from 2019 showed pretty similar results. So they had 89 fluoro-free supine ultrasound access cases, and 112 conventional fluoro access and conventional PCNL. They used ultrasound and nephroscopy to show residual stones or any complications. But even the fluoro-free group did get one post-op KUB to confirm the stone-free status. They had no significant differences in stone-free rates or complications between the groups. And in fact, the authors actually thought the fluoro-free post-procedure outcomes were better than the fluoro group because they felt that they needed to place less double J stents than in the fluoro group. And then here, similar safety and effectiveness results were found for fluoro-free ureteroscopy and holmium lithotripsy studies. So this one is from 2019, and it shows that there were no difference in post-op or pre-op complications. So here they used direct vision and tactile feedback to place the guide wires, sheaths, and stents. So because of this, the authors actually noted that they did recommend fluoro use for more junior surgeons until they became experienced enough to know how things felt in order to do it properly. But they confirmed the distal coils with direct vision, and ultrasound was used to confirm the proximal coils instead of X-ray. And the fluoro-free group performed very similarly to the fluoro group here. This was essentially echoed in another study a year later. They had very similar methods using tactile feedback for the wire and stent placement, and then using direct vision for confirmation of the distal coil. One extra thing that this group did was what's shown in the picture here. So they used the ureteroscope to measure the length of the ureter and how far up to put the access sheath. So they would basically measure how far it went in, took a note of that, and then measured the sheath next to it. So in the study, 567 patients underwent the fluoro-free URS and holmium laser. They were converted to fluoro use if they couldn't find the stone, if the double J stent or access sheath could not easily be inserted, or the endoscopic view was poor because of hemorrhage, or the surgeon actually just preferred to use fluoro. They did not report directly comparative data between the fluoro and non-fluoro methods, but they did report that 96.7% of patients had a successfully fluoro-free procedure, and there was a complication rate of only 11.8%. And given that one of the reasons for switching from non-fluoro to fluoro was the surgeon just didn't want to do it non-fluoro, that could be a little bit higher than 96.7 that could have been successful. And then a third study from last year had similar methods to the last two, but they were a bit more specific and went kind of beyond just the tactile feedback for insertion of the wires and stents. So they also used the typical lengths of female and male GU systems to determine how far to insert the wire. So they would mark 100 centimeters in males or 110 centimeters in females on the wire to show how far they should put it in. And when inserting the stent, they would look at the markings under direct vision to determine how far the stent was going up. They had lower complication rates reported than both the previous studies, so 3% for fluoro-free and 5% for the fluoro group. Similar to the previous study, those in the fluoro-free group were converted to the fluoro group if there were some issues. So those were excessive resistance when putting in the guide wire, non-concordant guide wire measurements, or they were unsuccessful getting the ureteroscope to the stone, or they suspected the JA stent was not placed correctly for any reason. 93% of the procedures were successfully completed without fluoro. And again, it was deemed safe, effective, and feasible. So lastly, there's a study regarding fluoro-free stent placement. So tactile feedback, again, was used with low dose settings that I had talked about earlier. They also used a measurement method where they used the ureteroscope to measure the ureter by marking the scope when it was in the kidney, and then again when it was at the UVJ to see how long the ureter was. They confirmed the distal coil of the stent under direct vision, and they found that the fluoro-free method was actually nearly twice as fast and had a similar complication rate of 1% as when they used fluoroscopy. So to summarize here, radiation is everywhere. It's the ionizing radiation that we're most concerned with due to their deterministic and stochastic effects that it can cause. It has many forms of measurement and is absorbed by each tissue differently. We irradiate ourselves a lot and our patients as well, which can lead to malignancy, but lead is pretty good at blocking it if we wear it properly. We can protect ourselves and our patients even more by using less radiation, whether by modifying our settings or using these new fluoro-free practices. And overall, it's important to be thoughtful when using radiation because it's not a benign thing, even though we can't feel it at the time. And it's our job to inform our patients of the risks of radiation as well, because they often don't know that there are risks or they don't know what the risks are. And some of our patients were actually irradiating quite a lot. So it would be worth it for them to know what's happening. But that's the end. So thank you for listening. I can try and answer questions if you have any.